Hello everyone, I'm Dr. Adila Mokhtar, a consultant clinical oncologist. I hope everyone is well. Shortly, I will be presenting on the first line systemic therapy in advanced urothelial carcinoma. In my next presentation slides, I will be covering the different treatment goals in advanced urothelial cancer. We will also review the current treatment landscape in first-line setting and to discuss individualized as it means to support an optimal treatment. Significant advances have recently been made in the therapeutic landscape of metastatic urothelial carcinoma. Since the approval of cisplatin in 1978, treatment options for urothelial cancer remained fairly static. While there were some modifications in chemotherapeutic regimens such as dose-dance, methotrexate, vinblastine, doxorubicin, and MVAC, no fundamentally new treatment types emerged for decades. This situation changed in 2017 with the introduction of immune checkpoint inhibitors, which marked a turning point in the management of metastatic urothelial carcinoma. Following the approval of the first immune checkpoint inhibitors, several new agents became available, including additional immune checkpoint inhibitors and antibody drug conjugates. These developments were driven by pivotal phase 3 trials, Javelin, Checkmate 901, EV302 that evaluated novel chemotherapies and other treatments. This diagram is to show you the current landscape in advanced urothelial carcinoma. Clinical factors which influence treatment selection such as cisplatin eligibility and biomarkers. Treatment options for first line include platinum-based chemotherapy, followed by maintenance avelumab in non-progression disease. For cisplatin ineligible patient, immunotherapy or antibody drug conjugate enfortumab vedotin are now approved as one of the first-line treatment options. In the second-line treatment option include edafitinib is an FDA-approved in positive FGFR positive marker, single-agent enfortumab vedotin, and sacituzumab govitecan, which I will cover in my next lecture. This slide represents the ESMO clinical guideline in the management of advanced urothelial carcinoma. Platinum-based chemotherapy remains the first-line treatment option. Adding in immunotherapy, nivolumab with chemotherapy can improve the outcome. With the recent data emerging, antibody drug conjugate, enfortumab vedotin, and pembrolizumab has also been approved as one of the first-line treatment options with significant outcome. Similarly to ESMO clinical guideline, National Comprehensive Cancer Network (NCCN) has also outlined several treatment options in the first-line setting. These include platinum-based chemotherapy, immune checkpoint inhibitor, and antibody drug conjugate, enfortumab vedotin, and pembrolizumab. There are several factors to consider individualized first-line treatment. These include the efficacy, safety toxicity using evidence-based medicine, the effects on quality of life and the regimens of the treatment. We also need to look at the patient's characteristics such as the fitness, comorbidities, and social factors. We also need to understand the disease characteristics such as the histology, site of metastases, high or low tumor burden, and biomarkers. And not to forget, access and cost also play a big role in our treatment selection. Before we decide on our treatment selection, it is important that we look at our aim and goals. We need to understand the site, tumor burden, and whether the patient is symptomatic from the disease. For example, lymph node mets and low tumor burden have better prognosis compared to bone mets and high tumor burden disease. Also, we need to take into perspective the patient's background, as treatments may cause toxicity and affect the quality of life. Platinum-based chemotherapy has been used as first-line treatment for many years. This chart is to summarize the response rate, progression-free survival, and overall survival for single or combination chemotherapy. Selecting the type of platinum-based chemotherapy will depend on the performance status, cardiac disease, renal function, hearing loss, and neuropathy. Based on the Galsky criteria and Gupta criteria, patient has to have a good renal function of a minimum 30 ml per minute with no significant heart failure. EV302 is a phase 3 clinical trial which randomized 886 patients with previously untreated advanced urothelial carcinoma into enfortumab vedotin plus pembrolizumab arm or standard of care platinum-based chemotherapy. The dual primary endpoints include progression-free survival and overall survival. The secondary endpoints are to look at the safety and overall response rate. Based on the EV302 study, this Kaplan-Meier curve shows the median progression-free survival was significantly longer with enfortumab vedotin plus pembrolizumab, 12.5 months compared to chemotherapy, 6.3 months. Median overall survival was also significantly longer with enfortumab vedotin plus pembrolizumab. In conclusion, EV plus pembrolizumab demonstrated increased overall survival and progression-free survival outcomes. As you can see in this graph and table, combination enfortumab with pembrolizumab has significant higher response rate compared to chemotherapy. Based on the EV302 trial, it was reported that more than 50% of patients on enfortumab vedotin with pembrolizumab developed grade 3 skin reaction and peripheral neuropathy. It was also reported that some patients experienced blurry vision and high blood glucose. Serious adverse effects is higher in EV with pembrolizumab arm. This slide is to show the pooled safety analysis with those in the enfortumab vedotin and with pembrolizumab arm. In EV, real-world and clinical trial safety, 49.7% of patients experienced skin reactions and 10% had grade 3 skin reactions. Among the 75 patients who developed skin reaction, 59% had complete resolution and 41% had residual skin reaction. For patients who experienced peripheral neuropathy in the EV arm, 86% had residual neuropathy with more than half was grade 2. Based on the toxicity profile report, EV with pembrolizumab can be offered if patients are fit with performance status of 2 or less. They also need to have a good renal profile with creatinine clearance of more than 45 ml per minute. As EV can cause hyperglycemia, blood glucose control is important at baseline with HbA1c of less than 8%. Patients with significant corneal or retinal abnormality and more than grade 2 peripheral neuropathy are not recommended. Now we're going to move on to Checkmate 901 study, which is a phase 3 multinational open-label trial which randomized patients with previously untreated, unresectable, or advanced urothelial carcinoma to receive intravenous nivolumab at a dose of 360 milligram plus gemcitabine and cisplatin every 3 weeks for up to 6 cycles, followed by nivolumab every 4 weeks for a maximum of 2 years, or to receive gemcitabine with cisplatin alone every 3 weeks for up to 6 cycles. The primary outcomes were overall and progression-free survival. The objective response and safety were exploratory outcomes. Based on the Checkmate 901 study, a total of 608 patients underwent randomization. At a median follow-up of 33.6 months, overall survival was longer with nivolumab combination chemotherapy compared to chemotherapy alone, with the median survival was 21.7 months as compared with 18.9 months respectively. The overall survival was seen as early as after 6 months. Progression-free survival was also longer with the combination nivolumab and chemotherapy. The median progression-free survival was 7.9 months in the combination arm and 7.6 months in the chemotherapy alone arm. The combination nivolumab and gemcitabine has shown significant higher rate of grade 3 anemia, neutropenia, and nausea. Now we're going to discuss on the Javelin Bladder 100 study, which is a phase 3 randomized open-label trial which randomly assigned patients with unresectable, locally advanced or advanced urothelial cancer who did not have disease progression with first-line 4 to 6 cycles of platinum-based chemotherapy followed by maintenance avelumab compared to best supportive care. The primary endpoint was overall survival assessed among all patients who underwent randomization and among those with tumors positive programmed cell death ligand 1 PDL1. Secondary endpoints included progression-free survival and safety. This study has shown that among all 700 patients who underwent randomization, the addition of maintenance avelumab to best supportive care has significantly prolonged overall survival. The median overall survival was 21.4 months in the avelumab arm versus 14.3 months in the best supportive care arm. Avelumab has also significantly prolonged overall survival in the PDL1 positive population. Overall survival at 1 year was 79% in the avelumab group and 60% in the control best supportive group. The long-term analysis has also shown significant median overall survival benefit at 23.8 months compared to 15 months in best supportive care group. Based on the Javelin Bladder 100 study, the most common side effects reported in using avelumab were thyroid disorder and immune-related rash, but only small percentage continued to have skin toxicity after 12 months. It was also reported that there was a small risk that avelumab can increase lipase and amylase level, as well as interstitial lung disease, immune-related hepatitis, and nephritis. Based on the primary and long-term follow-up, overall, less than 20% of patients who had avelumab as maintenance following combination chemotherapy had grade 3 toxicity, and less than 10% of patients had to discontinue treatment due to adverse events. Now we're going to move on to discuss on the Keynote 361, which is a phase 3 randomized trial which randomized patients using pembrolizumab with chemotherapy compared to single-agent pembrolizumab and platinum-based chemotherapy alone. The result has shown that pembrolizumab to platinum-based chemotherapy for first-line treatment of advanced urothelial cancer did not provide a statistically significant benefit for progression-free survival or overall survival. Table is the summary for all side effects for first-line therapy in advanced urothelial cancer. Peripheral neuropathy and skin reactions are more commonly seen in EV plus pembrolizumab. The risk of anemia, neutropenia, and thrombocytopenia are higher in the combination nivolumab and chemotherapy. Avelumab in first-line maintenance has a low risk of skin reactions and hypothyroidism. Other than efficacy and toxicity, the other clinical considerations that need to be considered are the tumor burden disease. It has been reported that lymph node-only disease has better prognosis compared to bone metastases. Other than that, patients with higher body mass has higher risk of hyperglycemia with EV compared to chemotherapy with or without maintenance avelumab. In conclusion, there are factors to consider before choosing the right treatment for our patient. This will be based on the efficacy using evidence-based study, treatment duration, toxicities, disease characteristics, as well as patient's preference and cost. Before I end my presentation, I would like to summarize that there are more treatment options for advanced urothelial cancer, which include platinum-based chemotherapy, followed by maintenance avelumab. Avelumab has shown improved survival and progression-free survival in those with non-progression disease after chemotherapy. EV with pembrolizumab has also shown significant results and can be considered as the first-line treatment, but to take into account the toxicity. Shared decision-making and eligibility criteria and individualized approach are essential to ensure careful considerations of all first-line treatment options, taking into account individual patient differences.